Diabetes insipidus, a video by Gasir Madar. Diabetes insipidus is a condition that occurs when the kidneys are unable to conserve water as they perform their functions of filtering blood. Diabetes insipidus is categorized by excessive thirst and excretion of large amounts of severely diluted urine. Many assume that diabetes insipidus is related to diabetes mellitus. Even though the two disorders share the same first name and have a few of the same symptoms, diabetes mellitus type 1 and type 2 and diabetes insipidus are unrelated. Pathophysiology. Diabetes insipidus is a metabolic disorder in which the kidneys are unable to absorb normal amounts of water. The regulation of urine production occurs in the hypothalamus, which produces antidiuretic hormone. ADH is a hormone produced in a region of the brain called the hypothalamus. It is then stored and released from the pituitary gland, a small gland at the base of the brain. In addition, the hypothalamus regulates the sensation of thirst by sensing increases in serum osmolarity and relaying this information to the cortex. The main effector organ for fluid homeostasis is the kidney. ADH acts by increasing water permeability in the collecting ducts and distal convoluted tubule. Specifically, it acts on proteins called aquaporin, which open to allow water into collecting duct cells. This increases in permeability allows ducts reabsorption of water into bloodstream, thus concentrating the urine. Etiology. Diabetes insipidus caused by a lack of ADH is called central diabetes insipidus. When diabetes insipidus is caused by a failure of kidneys to respond to ADH, the condition is called nephrogenic diabetes insipidus. Central diabetes insipidus can be caused by a damage to the hypothalamus or pituitary gland as a result of head injury, infection, loss of blood supply to the gland, surgery, or tumor. Nephrogenic diabetes insipidus involves a defect in the part of the kidneys that reabsorbs water back into the bloodstream. It occurs less often than diabetes insipidus essential. Nephrogenic diabetes insipidus may occur as an inherited disorder in which male children receive the abnormal gene that causes the disease from their mother. Nephrogenic diabetes insipidus may also be caused by certain drugs, high levels of calcium in the body, or kidney. Assessment findings. The two main assessment findings that are categorized with diabetes insipidus is excessive urination and extreme thirst. The extreme urination continues throughout the day and continues through the night. In children, diabetes insipidus can interfere with appetite, eating, weight gain, and growth as well. They may present with fever, vomiting, and diarrhea. Risk factors. Some risk factors that might lead to diabetes insipidus are damage to the hypothalamus due to surgery, infection, tumor, or head injury, polycystic kidney disease, or any other kidney disease that may affect the filtration process, use of certain medications such as lithium, high blood levels of calcium, and low blood levels of potassium. Diagnostic testing. To diagnose diabetes insipidus, a doctor must determine which type of diabetes insipidus is involved before proper treatment can begin. It is not possible to diagnose diabetes insipidus until the symptoms of excessive thirst and urination are present. The diagnosis is initially evaluated by determining the daily intake and output of fluids, and then measuring blood and urine water balance after a 7-hour or longer period of water deprivation. The urinary measurement of vasopressin after a water fast can also be determined to diagnose diabetes insipidus. An MRI can demonstrate changes in the brain and pituitary area with DI, though an MRI cannot by itself diagnose DI. Signs and tests include MRI of the head, urinary analysis, urine output, fluid deprivation test. Priority nursing problems. Problem number 1. Fluid volume deficit related to active fluid volume loss. Problem number 2. Risk for impaired skin integrity related to altered fluid status. Nursing directives with rationales. Problem number 1. Intervention 1. Record daily weight of the patient. The degree of dehydration can be determined by the percent of weight loss the patient shows. Daily weights aid in determining process towards rehydration for the child. Number 2. Provide oral fluid and electrolyte replacement solution if able to tolerate. This provides for replacement of essential fluids and electrolytes. Number 3. Provide and maintain IV replacement therapy as ordered. Based on the degree of dehydration and ongoing losses, IV therapy aids in hydration. Problem number 2. Intervention 1. Assess skin of perineum and rectum for signs of skin breakdown or any irritation. Loss of fluid has an impact on the skin integrity, and early preventative measures can ease the condition. Number 2. If child wears a diaper, change the diaper every 2 hours or as needed. This helps minimize skin intact with stool and urine. Number 3. Provide the child in a prone position and leave the buttocks open to air. This helps promote air circulation to the area. Potential health problems. Without medical treatment, the possible complications of diabetes insipidus include chronic dehydration, low body temperature, accelerated heart rate, weight loss, fatigue, frequent headaches, low blood pressure, kidney damage, and brain damage. Clinical interventions, pharmacological. Firstly, administer hypotonic saline IV. Administer antidiuretics if prescribed, depending on the patient's situation. Administer desmopressin acetate, also known as DDAVP. This medication is a synthetic form of ADH. Administer vasopressin. This drug is the aqueous form of ADH. If vasopressin is given, monitor for water intoxicity. Clinical interventions, non-pharmacological. Instruct the patient to wear a medical alert bracelet listing diabetes insipidus and the medications that the patient is using. Full body assessment, paying close attention to circulatory and skin. Allow patient to drink water as well. Make sure the patient has easy access to the bathroom or bedpan and answer his calls signals promptly. Use skin barriers as needed. Growth and development. Growth and development are important indicators of a child's overall health. If diabetes insipidus is left untreated or not treated properly, it could have negative effects on the child. Infants with diabetes insipidus may eat poorly and excrete all the nutrients through the urine, causing them to develop failure to thrive. Bedwetting and extreme urination can also be detrimental to a child's self-esteem. Community resources. The outcome of diabetes insipidus depends on the underlying disorder. If treated, it does not cause severe problems or reduce life expectancy. For question and answers, please visit diabetesinsipidus.org. For further information, feel free to visit the City of Ottawa's Diabetes Education Program.